that's all about the compliance of the lungs and how the surface tension would typically contribute to compliance and how surfactant helps to combat that surface tension. In other words, keep the compliance nice and high. Now, the second thing we'll speak about here is the airway resistance. And this is basically the impedance to airflow that's seen throughout the airway. And we talked earlier about some of the factors that contribute to resistance, such as mucus, such as the radius of the airway. And so it would kind of be one would be tempted to think that as the airway gets smaller and the radius gets smaller, that the resistance would increase, right? We would sort of be tempted to think that way, but in actuality, that's not true, okay? The resistance is kept very low because of the extensive branching that's seen throughout the airway. And this is very similar to what we saw with capillaries. So although the radius, the internal lumen of capillaries gets smaller than it is in arterioles, there just is so much extensive branching in the capillaries. Same thing here in the airway. There's so much extensive branching that the resistance is kept overall low, although the diameter, the radius gets smaller. And so in our typical lung, we keep the resistance low. And so a pressure gradient is needed for airflow. And so we typically see a gradient of about 1 to 2 millimeters of mercury. But if we increase the resistance, we're going to need a bigger gradient in order to keep air flowing, okay? I'll say that again. Typically, we have a pressure gradient of about 1 to 2 millimeters of mercury, and that is when our resistance is kept low, right? But if we increase our resistance, if there's more mucus in the airway, if there's bronchoconstriction happening, we are going to need a bigger pressure gradient to accommodate the same amount of airflow. And so our pressure gradient is going to have to be bigger than that typical 1 to 2 millimeters of mercury. Okay, it's going to be just so much harder to get air in because of that impedance to airflow. And thinking back to our bulk flow equation, right? Pressure gradient divided by resistance is equal to bulk flow. And so if I increase resistance, I'm going to have to increase my pressure gradient in order to keep my flow constant. Okay, here is a graph that kind of depicts this a little bit better. So what we're seeing here is the change in pressure. So our intraalveolar pressure here on the left. At the bottom, we're also seeing the corresponding change in volume, right? The amount of air that's being moved. And so the slope of this curve, we've got two different curves here. One is showing the change in pressure that is required under normal resistance. So if my resistance was nice and low, I would only need a gradient of about 1 millimeters of mercury difference, right? A difference in this pressure in my alveoli in order to move air in. But if I increase my resistance, I'm going to need a much bigger gradient. I'm going to need twice the size of the gradient to accommodate the exact same amount of air moving in. And a more simpler way to say this is, if my resistance goes up, my lungs have to work twice as hard to move the exact same volume of air in and out, okay? And so it's going to require a bigger change in pressures. And we know that what creates the change in pressures is the work or the effort that's exerted by the respiratory muscles. So my diaphragm is going to have to work really hard. My external intercostals are going to have to work even harder, right? Twice as hard to create a bigger gradient, twice as much of a gradient to move the exact same amount of air in. And that is not ideal. So it's really important that we keep resistance low in order for the lungs to accommodate airflow with very little effort in terms of the exertion that's required to create the pressure gradient. Okay, looking at some of the factors that affect our resistance here. So we've got some passive forces. So basically the mechanics of breathing itself can affect airway resistance. So we spoke about the change in transpulmonary pressure, or that distending pressure that happens naturally as we move air in. And so during inspiration, as I increase that transpulmonary pressure, I'm basically expanding the airway. I'm pulling on the alveolus, and so that is going to reduce my resistance. As the thoracic cavity pulls on the pleural connection, pulls on the alveolus, I'm basically expanding the alveoli, I'm decreasing any resistance. Another one is the tractive forces. So again, during inspiration, sort of similarly here, as we move more tissue away from the airway. So think about the airway as being the central portion of our respiratory structures. As the alveoli expand, they actually move away from those central portions of the airway. And so again, I'm creating less obstruction, less compression on those airway structures, and that will too pull the airway open and decrease any resistance to airflow. Other two factors are going to be the contractile state of smooth muscle. So we talked about the idea that along the distal parts of the airway, we have this exchange of cartilage for smooth muscle, and the presence of that smooth muscle allows us to modify the diameter of the airway. And so if we constrict on that smooth muscle, we're going to increase resistance. If we relax that smooth muscle, we're going to decrease resistance. And then the final factor is mucus secretion. And this really comes into play in terms of our inflammatory response. So mucus is usually created as a result or as a response to any type of inflammation in the airway. And so excess mucus is going to increase viscosity. Remember, viscosity is one of the factors that affects resistance. And so that will too be an impedance to flow if there's excess mucus present in the airway. Okay. All right, I'm going to pause here for just a second and see what questions we have. All right. So getting a little bit more into the details of modulating or regulating the airway resistance, this is basically regulating the state of the smooth muscle within the airway. And so there are two states of that smooth muscle. We can have bronchoconstriction, which is the contraction of that smooth muscle that causes the radius to decrease or become smaller. And obviously that's going to make it harder for air to come in, right? That's going to be an impedance to flow. And then there's bronchodilation, which is the relaxation of the smooth muscle. That's going to cause the radius to increase. And that is going to allow for more airflow or less resistance to airflow, okay? And so the contractile state of that bronchial smooth muscle is under the influence of intrinsic and extrinsic controls, much like what we spoke about in the arterioles. We've got some local factors that influence the state of that smooth muscle, right? We've got some extrinsic factors. And when we talk about extrinsic, we're usually referring to hormones, we're referring to neurotransmitters, we're referring to the autonomic nervous system and its involvement in that more extrinsic regulation of the smooth muscle. So here's what that airway looks like under normal circumstances. We have the airway nice and open, nice and patent. We've got the smooth muscle, which is surrounding the airway, sort of relaxed in order to accommodate adequate airflow down into the alveoli. Okay, let's speak about some of the extrinsic controls here. So this is going to involve the autonomic nervous system, right? The sympathetic division is going to cause relaxation of smooth muscle. That's going to be bronchodilation. And then the parasympathetic system is going to have the opposite effect. It's going to contract that smooth muscle, and that is going to cause bronchoconstriction. And so if we think about this on a more practical level, we think about that fight or flight or freeze response, which is the sympathetic influence or the sympathetic response. And so if I'm under that state of fight or flight or freeze, I want to bring more air in, right? That's going to help me mobilize oxygen to my tissues. That's going to help me flee from a threat. That's going to help me be more alert, right? It's going to bring more oxygen to the brain. And so in doing so, I would want to relax that smooth muscle. I would want to bronchodilate as a response to the fight, to the sympathetic nervous system. On the other end of the spectrum, we've got the parasympathetic, which is that rest and digest. And obviously, if you're resting, and even more so if you're digesting or eating, you don't need to bring as much oxygen in, you don't need to bring as much airflow in, and so you can contract that smooth muscle or bronchoconstrict, okay? And if you remember us speaking about, and I'll kind of just make this connection here, we spoke about the beta-2 receptors last semester. So beta-2 receptors present in the airway, so along the bronchiolar airway and in the lungs. And so beta-2 receptors had an inhibitory response to their tissues, right? We spoke about this. One of the few second messengers that had an inhibitory response, although it increased cyclic AMP, which was its second messenger, that brought about an inhibitory response. And this is exactly why, right? In other areas of the body, we want to vasoconstrict as a response to the sympathetic system. But here in the lungs, it's a little bit opposite. It's a little bit reversed. We actually want to bronchodilate to bring more air in. And so this is why the sympathetic response, right, the binding of norepinephrine to these beta-2 receptors brought about an inhibitory response on the tissues, because that is what would be ideal for the sympathetic response within the lungs, okay? All right, just making a little bit of a connection there to the autonomic nervous system that we talked about last semester. Looking at some of the extrinsic controls here, we've got hormones involved. So hormones are playing the exact same role as epinephrine does, right? Binding to that beta-2 receptors. We've also got epinephrine itself acting as a hormone or as a neurotransmitter. And that's going to bring about relaxation of smooth muscle, in other words, bronchodilation, in other words, more airflow coming in, less resistance coming in, a larger lumen or a larger radius of the airway. And then some of the intrinsic controls are going to be histamine. So these are some of the local factors. So histamine is one. And we talked about histamine as it applied to capillaries before. Histamine is actually one of those inflammatory markers. It's going to be released or secreted as a part of the inflammatory response. And so it's usually secreted as a part of an asthmatic attack or an allergy of some sort. And it basically increases the amount of mucus secretion. And the sort of the backstory here is the body thinks that if there's any type of irritant in the airway, the next thing that I need to do is constrict the airway and then secrete mucus to help trap that irritant. And so that is the reason why histamine brings about these responses. It's going to constrict on the airway, create bronchoconstriction, and it's going to create lots of mucus because that is the body's inflammatory response. It's going to be trying to trap whatever irritant that is, irritating the airway. And so usually in people who have allergies, so if you have allergy to peanuts or to any type of other compound or molecule, or if you get bitten by a bee or something like that, the natural response of your lungs is to constrict the airway and to secrete lots of mucus. And as you would imagine, that can be very detrimental to bringing oxygen in. And that's why this can be fatal if you have a really extreme allergic, reaction. And then the other local factor here is CO2. So lots of CO2 present in the blood circulating the lungs is going to cause bronchodilation. It's just a way of saying that there's increased demand for oxygen to come in and increased demand for airflow, right? We need to lose that CO2. And so we need to bring more air in order to exchange that CO2 and eliminate it from the body. And so the response would be to cause bronchodilation in order to do that. Okay. All right. So we spoke about some of the extrinsic controls, hormones and neurotransmitters. And then we talked about some of the intrinsic controls, histamine, which causes bronchoconstriction, and CO2, which causes bronchodilation. All right. What we'll speak about now is sort of the pathological connection to this in terms of two diseased states. So one is asthma and the other is COPD. And both of these have a similar etiology, like they have a similar disease process that's happening, but the progression is a little bit more different. So asthma is more of an acute disease. It's going to cause spastic constrictions or this bronchospasm, this spasmodic reaction to the bronchial smooth muscle, where it makes it very hard for air to move in either direction. So it's not moving in or out because of this spasming of the smooth muscle that's lining the airway. And then COPD has a similar effect, but it's going to be a different progression. COPD is usually very chronic. And And so it's going to be more sustained. It's usually more than 2 years, sometimes 3 years is the diagnostic criteria for COPD, which is chronic obstructive pulmonary disease. And so both of these diseases are going to be created usually in response to, again, some type of airway irritant. COPD is almost exclusively found in smokers. And so that's one of the diagnostic criteria for COPD. You have to be a long time chronic smoker, otherwise it's not likely to be COPD. And so again, that smoking being that airway irritant creates this environment where the smooth muscle just really is so irritated that it constricts on itself, and it creates this hard, this increased resistance to airflow coming in. Same thing with asthma, but again, in a more acute way. And we know of some of the asthmatic irritants, so usually environmental exposure, sometimes extremely cold air can be an irritant for asthma, pet dander, lots of other irritants in the environment. And it creates the same type of environment where the lungs think that they're being attacked, and so they constrict on themselves and secrete lots of mucus, okay? All right, I see a question here. Okay, so the question is, in the parasympathetic system, it's a smooth muscle that is constricting. Yes, that's true. Usually during that parasympathetic influence, and it's not constricting in a way to close off the airway, but it's just not dilating, right? It's just more closed off because that's what's needed at that time. Less airflow is needed or required during that parasympathetic influence or parasympathetic state. And so it's not closing off the airway, but it's just constricting to minimize airflow, which is, required at that time. And then the second part of the question here, histamine causes bronchoconstriction as a part of an inflammatory or anti-inflammatory or more of a sympathetic response. So yes, histamine is going to be, it's a local factor, so it's not going to be involved in the sympathetic. So make sure you're making that distinction. So it's a local factor, not involving the autonomic nervous system in any way, not involving integrating centers or the brain or any neurons. It's released from the lungs, and it's creating that bronchoconstriction as well as mucus production locally within the airway, okay? All right, I hope I answered that question. Yeah, so basically asthma, COPD, two pathologic states that create a lot of airway resistance, decreased flow. And what we'll move on to see is when we talk about these obstructive lung diseases. So asthma and COPD are both examples of obstructive lung diseases because the airway is not only facilitating airflow in, it's also facilitating airflow out. These patients usually end up having what's called air trapping. They trap air inside the lungs, and so the lungs become really large, really inflated. And so you'll be able to notice or to spot a COPD patient because they'll have really large barrel-shaped chests because of all that air that they're trapping, because the airway is not facilitating air coming in, neither is it facilitating air moving out, okay? And so they trap or hold on to that excess air, and we see the chest become really large, really expanded.